I just want to say good morning to everybody. It is lovely to have you here. We're expecting quite a big group here today, and part of the reason is because it's the last tutorial. Today we're going to get down to the nitty-gritty of actually testing people. You now have a good background history of the brain, of pathology, of differences between the hemispheres, between the different sexes, and today we're going to be talking about what we do when we actually test people and write reports on them, and when we appear in court. Because whenever we test somebody, we must assume that this is likely to end up in court. So we need to test them accordingly. Now, before I touch on anything else, I just want to run through the people the other professions that we tend to get in touch with or that are involved in our assessment in one way or another. The paramedics are usually often the first people at a scene of an accident, or if there's been something that has happened, for example, someone's had a stroke and an ambulance has been called out. So they are the people who write down what the person's Glasgow Coma Scale score was initially, etc., and what it was that was obviously, or what they could detect that was wrong. And this is very important, and one needs to look at what time they received the call out, that's normally on the ambulance form, and what time they arrived at the scene, and then what they did at the scene. Did they intubate the person? Was the person conscious, unconscious, etc.? Then, of course, the person goes to hospital, and the nurses write down copious notes. And those notes are very important because it's often the nurses that detect if the person has started speaking, how alert they are, what their Glasgow Coma Scale is. And the radiologists, we often get radiology reports indicating what the brain scans have said of the person. The occupational therapists often have their notes written in the hospital notes, indicating what they find with the person, also looking at things like alertness and mobility. Speech and hearing therapists are not always involved, but they are often involved if the person is having difficulty swallowing or with speech. Orthopedic surgeons tend to be involved if they have had problems with broken legs and arms and so on, and that is usually not all that applicable to us, but we need to look through their reports because they will sometimes note, for example, level of consciousness or alertness of the person. The neurologists, their reports are very important to us, obviously, and we need to see what they say about the diagnosis, and the neurosurgeons as well. Psychiatrists are not always involved, but often after there's been some other cerebral incident, some people eventually land by a psychiatrist who will look at the emotional assessment of the person. And we know that emotions are based in our brain, so what the psychiatrist has to say is very important to us. The clinical psychologists who might be involved, also important. And then once we've written our neuropsych reports, it goes often to an industrial psychologist. It's the industrial psychologist who will determine what this person's career path probably would have been were it not for the accident or stroke or whatever, and what it is likely to be now based on our findings. And finally, those reports, we never really see the reports of actuaries, but eventually it goes to an actuary who then works out the calculations. What would this person have earned compared to what they can now possibly earn? And that's a calculation that only they really are qualified to do. So these are all the people that we interact with when we do neuropsychological assessments. Now, something that's very, very important, I'm sure you all know this, but I've got to mention it anyway, is do not use tests in isolation. We do not go and just test people and use the test results. We look at a wide range of things, and I've said this before, but you look at the medical documents such as hospital notes, brain scan reports. Collateral information is very important, such as interviews with significant others, parents, teachers, spouses. Evidence of pre-morbid functioning, such as school reports, very important. I'm going to talk more on that later. Your clinical observations, you need to have your eyes wide open, and having what you've studied now already, you find you're going to be much more observant because you know what types of things to look out for. And then understanding of patterns in anatomy and physiology. Unless you understand those patterns, you understand how the brain works, it's very difficult to try and really understand what you're finding in the neuropsychological assessment. And before you even start your assessment, you need to ask yourself, what is the assessment for? Because you need to ask yourself, you need to know, I mean, one can be asked to do an assessment for very many different reasons. And the reason for the assessment will very much tailor what test you choose, how you go about the assessment, how you write the report. So often, in our case, we're looking at pre- and post-morbid differences. Example with road accident fund cases or medical negligence cases. You want to know how was the person performing beforehand, how they're performing now, what is the difference. But often we're asked to assess a child's school performance because they're just not really doing very well at school, there's been something wrong, and we need it for that reason. Sometimes we need to assess the person's ability to manage their personal finances or make legal decisions, and the attorneys or family members then want to appoint a curator, like a curator bonus or a curator ad litem, or a curator persona. Can a person care for themselves? You know, if this is somebody who has really had a very severe stroke or something like that, and they feel they can care for themselves, you might have family members coming and say, please assess this person. We're not so sure that they can really live on their own, take care of themselves. Competence to return to work. Some people might feel they don't want to return to work and feel that they're not able to return to work, and sometimes you need the objective neuropsychological assessment to determine whether they are capable of returning to work or not, whether they can drive. Sometimes your assessment is just to aid a diagnosis. You might have a neurologist referring a patient saying, look, it looks like this person might have dementia. I don't know what type of dementia. Can you assess the person and help me with the diagnosis? Sometimes the assessment is to guide with rehabilitation. You know, what can the person do? What can't they do? What can physiotherapists and occupational therapists help, or speech therapists help the person with? Helping families to know what to expect. I think that's a very important aspect of assessment. Sometimes we're called to look at assess for criminal matters. If somebody has committed a crime, are they fully responsible for it, or is there some sort of organic reason that has led them to behave in certain ways that has made them commit the crime, or that has assisted them to commit the crime? And one needs to know that, because if there's an organic explanation for their behavior, then they're less culpable than if they have nothing wrong with them. Sometimes you'll get a psychiatrist to refer the patient because they want to know, is what they're looking at, the behavior of the patient, is it organic or is it psychiatric? And then sometimes you're asked to assess a person for the effectiveness of a treatment technique. So you might, for example, have clinical trials where people are on drugs, and you might be called in to assess people before they start taking the medication and after, and perhaps during the time that they're taking the medication. I'm going to be running through this quite quickly today, but please feel free, if you have a question, you can stop me and ask me. But I am going to be going through it quite quickly because today we have a lot of work to cover. Yes?
Who would be the referring agent?
You can get referrals from psychiatrists, neurologists, attorneys, family members, from the patients themselves, parents, school teachers. Your referrals can come from many, many different sources.
Even a court order, perhaps?
Unlikely. It's unlikely that a court would order a neuropsychological assessment. I think you're more likely to find an attorney or an advocate would want a neuropsychological assessment to aid them in their argument. By the time it gets to court, all those things have already been done. Might be different in a custody matter. You know, if there's a custody matter, and when it comes to custody matters, as neuropsychologists, we don't tend to get all that involved unless the one person has some sort of, looks like they have some sort of brain injury or a stroke or something strange about their behavior that might be explained by neuropsychological assessment. But otherwise, we tend to not really get involved with that. Now, when you do an assessment, something very important to bear in mind is what we call differential diagnosis, and Lizak put it quite nicely. She says, which of two or more diagnostic pigeonholes best suits a patient's behavior? So you've gone through your Lizak and you've gone through all your notes and you know all the different pathologies, you test the person. It's very seldom that you have a clear picture emerging of exactly what this person's diagnosis is. But you need to try and choose the best fit for that person. And examples where this is very important is, for example, distinguishing between impaired spatial ability or motor ability. Somebody might be falling around, they struggle up and down stairs, but is it because they have a motor problem or is it because they have a spatial problem? And that's where neuropsychologists can help. Or does the person have dyslexia or poor memory for what they've been reading? You get some people say, I can't read anymore. Well, is it that you can't read the words? Or is it that by the time you get to the end of the paragraph, you can't remember what it said in the beginning of the paragraph? So distinguishing those problems, those difficulties. Dementing disorders versus normal aging. We all know that our memories start to go and so on as we age. So what is normal and what is a dementia? Alzheimer's or frontotemporal dementia. Eventually, once Alzheimer's has progressed quite far, and once frontotemporal dementia has advanced quite far, they look very much the same. So what is the difference? Because that could depend on what medication the doctor gives them. Does a person have depression or dementia? We know that a person with depression tends to have very poor memory. So is it poor memory because of depression, or is it poor memory because of dementia? And the neuropsychologist can assess that. And then a neurological versus a psychiatric or psychological disorder. Again, looking at per person's behavior. Is it psychiatric? Is there an organic reason? And you normally, if you've got that kind of question, is it psychiatric or is it organic, you're probably going to be testing for executive functions. Okay, now just very basically, for your neuropsychological assessment, you have these different components. You get your referral, you choose your tests, you prepare your assessment, you prepare the client. I'm going to talk about that in a moment. You do the interview, you do the testing. Now, when you're planning the assessment, you need to have an overall approach to the problem. You need to know what it is that you're looking for and why. And before you even start that planning, you need to request the medical documents. Now, sometimes there aren't medical documents. For example, if you get a referral from a psychiatrist, it's unlikely that they're going to be hospital notes and that kind of thing that they can send. But if it's, for example, someone who's been in an accident, there will be hospital notes that the attorneys will send to you, and you normally don't even need to request it. They normally just send it to you straight away. But if you haven't got it, you need to get it, and you need to read through them fairly carefully before you start assessing, so that you know what you're looking for.
Do you need the written permission of that patient before you can request the documents?
I'm going to get, no, not before you can request the documents. But it depends. You see, if an attorney sends it to you, then the attorney has already received the consent from that patient to share their information. If it's not referred through an attorney, then you would need the person's permission, because you're not allowed to just look at people's private records without their consent.
Sharon, does the attorney's referral also cover collateral?
You mean that they got information from collateral?
No, that the authorization to get information, either medical reports or collateral, is covered by the consent that the attorney has.
Yes. The attorney normally gets consent to get all information and distribute it to the people that they feel is reasonable. You'll see later that I always just have a separate form of my own, consent form of my own, just to cover myself doubly. Okay, you need to know what questions you want answered, and then you need to plan which tests you're going to use to try and answer those questions. So if you want to know, does this person have a frontal lobe dementia or something wrong with the frontal lobes, well, then you need to include tests of executive functioning. Is the main issue around memory? Well, then you need to have a couple of memory tests. And you can't do all the tests on every person. That's just not practical. But so you need to think carefully about what you want to answer through the test, so that you choose your tests appropriately. And then you prepare your tests. You get them all ready, because you don't want to be scuttling around on the day of the assessment going to fetch out of your testing cupboard the test that you want to use. You want to have it all ready, because time is an issue, and I'm sure all of you know, those that do assessments, they are time consuming already. So you want to have it all ready before you've even started. Now, what affects how what test you choose for the person? Well, again, what is the referral question? The age. some tests are for children, some tests are for adults, some are for adolescents. You need to make sure that the test you choose is for the age that you're looking for, and that you have norms for that age group. What is their home language? Some tests we can only do in English because they come from the UK and America, and we don't have our Afrikaans versions for them. Some of our tests we've had Afrikaans translations, but some of them we don't. So you can't choose an English test for somebody who doesn't have a first language of English, or is at least very proficient in English.
And if you have a causal patient?
That is a real challenge, and I'm going to talk about translators in a moment. You need to think about the person's general intelligence and level and quality of schooling, and this is why it's important again to look through those medical notes, because that gives you a sense, is this person coming in a wheelchair? They cannot speak, they're barely conscious, they're barely alert. Or is this somebody who's going to be walking in and they've returned to work but there's some problems? You need to tailor your tests for that person's functioning, ability to function. It doesn't help you give them an IQ test if they can hardly speak. Okay. Previous assessments. If there have been previous assessments, try not to use the same tests, because depending on how long before the person's had the assessment. If it was 6 months or so before, then you can possibly try and use the same test, also depending on the person's level of intelligence. If you've got a super, super bright person, and they did this test 6 months before, they're probably going to remember it, so don't do it again. Rather use an alternate version if you can, or a different test to try and test the same functions. And then the time period. If the person's just had a traumatic brain injury, it doesn't help you test them while they're still in the hospital, unless your aim is to try and guide the rehab people and give some indication to the parents or the family members of how the person's doing. But if you want to look at how the person is functioning and looking into the future, whether they can return to work, earn an income, etc., you need to wait at least 2 years before you test that person. And then again, you need to choose the tests accordingly. The order of the test, the order in which you do the test is very important. If you're doing a test, for example, your rare complex figure test, and you have a recall that you want to do 30 minutes later, you shouldn't then, after you've given them the complex figure, then give them all sorts of other visuospatial drawing types of things, because it's going to interfere with their ability to recall it 30 minutes later. So steer clear of visuospatial things, and after you've done the recall, then you can give them other visuospatial tasks to do. And then validity. Does this test measure what it purports to measure? Those of you all have LESAC, so you know that in LESAC there are reports of many different tests. And there are new tests that are being developed all the time. But does it measure what it is meant to measure? And you need to check that, and thankfully we have books like LESAC where it will give the validity studies that have been done on the test. If it doesn't have validity studies, then you must assume, well, it's not valid until it's been proven to be valid. And then you'll see in LESAC she mentions face validity. Does it appear to measure what it's supposed to measure? As neuropsychologists, we can't go according to what it looks like this test measures. We need to go and find out exactly what does it really measure. And we must bear in mind that patients doing these tests, they're also going to be judging the test according to what they think it's going to measure. And if it's somebody who's trying to exaggerate their symptoms, they might then try and exaggerate it according to what they think the test is going to measure. And one just needs to be aware of that. And ecological validity. Does this measure predict behavior in everyday situations? For example, to be able to return to work or ability to drive. Now, not all of our tests, we have the information on it, but some interesting studies have been done. For example, impairments on measures of executive functioning, intellectual functioning and memory were the best predictors of employment status. That was found in 2013. So one can bear that in mind. Another interesting study that was done is to determine driving ability in older adults, one needs to have them sent for standard vision screening and assess their speed of processing, visuospatial processing and memory. This article about driving, you can find that on the website, on the Neuropsychology SA website. Just further aspects affecting test choice: reliability. I'm not going to go into that. Sensitivity. Sensitivity, it measures the proportion of actual positives which are correctly identified. For example, the percentage of sick people who are correctly identified as having the condition. So it's useful for ruling out the presence of a disorder. So for example, verbal paired associates of the visual memory scale, which you'll see over there, is very sensitive to dementia. Okay. So if somebody does very badly in the verbal paired associates, then there's a very good chance that they have dementia. Then we also need to look at the specificity of tests. Now, specificity, it measures the proportion of negatives which are correctly identified as such. For example, the percentage of healthy people who are correctly identified as not having the condition. And it's useful for ruling in the presence of a disorder. For example, a reading test from an aphasia examination is easily passed by literate adults. So someone who does poorly in it has a disorder. So when you choose a test, you need to look up in LESAC or which Spreen and Strauss, whichever reference you're using, what is the sensitivity, what is the specificity? Because if somebody does very poorly on a test, to what extent does that mean that they really are dysfunctional in whatever that test is measuring? We need to just be aware of that. You also need to think about how long is the test battery, as it doesn't help you do all the tests you have on the person. Time is an issue, cost is an issue. If you're going to charge per hour that you charge, and you've got to score all these tests, and you've got to write up all of this in a report, if you do a lot of tests, you're going to be spending an awful lot of time on this person, and if you're expecting them to pay for it and you've tested them more than you need to, that's not really fair. On the other hand, you can't keep it so short that you're not testing everything that you need to test. But also depends on, again, what the referral question is. I had the privilege of working in a neurocare hospital where there was tremendous time pressure. You know, the person would be admitted, let's say on the Tuesday, they're leaving on the Friday, and the nursing staff and the physios and occupational therapists need to know what is the status of this person. So you need to test them on the day that they come in or the following day, but you've already got a full diary. So you tend to shorten the assessment. You basically do a screening assessment. Okay, well, let's spend an hour or two with this person, do a very quick brief report, and get it to the people that need the information, which is a very different type of assessment to doing a medico-legal assessment, where, and especially if it's a criminal matter, you need to test just about everything, and then maybe over a couple of days. And so you need to just weigh up time and cost to what the information is that you really want to get. Every now and again, if I assess a patient, I'll realize that there is more information I need to get from this person. I'm not going to be able to do it today. Then I'll try and schedule another day for them to come in. But that's not always practical, because some people travel very far to come for your assessment, and they're only here for a day. So one needs to weigh up all these things. And then always try and finish with an easy test. Something that people can, because some of these tests people can find very difficult, and you don't want them leaving thinking, oh, that was terrible, and I never want to do this again. If you try and finish with an easy test, they're more likely to leave there thinking, oh, actually that wasn't so bad. Now we have a psychometrics committee of the professional board for psychology, and they have a list of tests that are classified as psychological tests. And I've given you this link because if you go on this link, you will see a long list of the tests that are classified as being psychological tests. Those are tests that only psychologists can administer. And you will see, if you haven't already, that sometimes occupational therapists use some of our tests. And if you find that happening, it's your responsibility to report it to the Psychometrics committee, because they then need to contact the occupational therapist and say, look, you're not supposed to be using this test. Okay. Quick mention about the examination room. You can't go sit next to a busy road and test a person. You need an examination room. And just some guidance there, you need a clear desk. You can't test somebody who's got piles and piles of things. Because remember, you want them not to be too distracted when they're busy doing their testing. You want to elicit the best out of this person. Limited noise. You can't expect it to always be noise-free. A room preferably without distractions. Natural light, because when you sit and test for so many hours, sometimes if you don't have natural light, it can really be quite disturbing to a person. Try to remember not to have any time or dates visible, like clocks, calendars, especially if you're asking orientation questions. What is the time? What is the date? It doesn't help you have the newspaper on the desk with the date in front of it lying right there. Temperature control. The person needs to be comfortable. They mustn't be getting so hot that they can't concentrate or so cold that they can't concentrate. Your rooms need to have wheelchair accessibility for obvious reasons, preferably a waiting room so that loved ones and significant others can wait for them. It needs to be secure. That means your security as well as their security. You need to, some people can be quite volatile, and you just need to know that you're not alone in the building, locked up. You've got a receptionist outside or a colleague outside or somebody just there as well. An examiner must dress up.
Accusations of sexual impropriety.
Yes, and to prevent accusations of sexual impropriety. And which brings me to that point, dress appropriately. I know that I've read things that a book where it says that ideally you should be wearing your white coat when you do an assessment. But I think that is much too anxiety provoking. But just as long as you're not wearing jewelry that is dangly, something that's too revealing, anything that's going to distract a person, you should just think about what you wear when you do an assessment. Now, preparing the client. Does the client know about the purpose of the assessment? This is quite difficult. If the referral is coming through an attorney, then the client knows, usually, unless they're really quite impaired. But you often get referrals through neurologists or psychiatrists, or especially family members, where they bring somebody in and that person doesn't know why they're being tested. And that can be very tricky, because then you need to tell the person why they're being tested without upsetting them. Okay? The payment must be agreed before the first appointment. You can't expect the person to come in and then you tell them what it's going to cost. Or you've already done the assessment and then you tell them what it's going to cost. You know, that's really not right, and it's not fair. So that must be negotiated and understood and agreed upon before that first assessment.
Depending on who's paying.
Well, no matter who's paying, you need to have that agreed with before.
In the medical legal case?
You need to have that in agreement with the attorney.
With the attorney, yes, but not with the patient.
But not with the patient, quite right, yes. Yes. I normally send out an email when the appointment is confirmed, just to remind the person to try and have a good night's sleep, to bring information about their medication, that they must have breakfast before they come, so the person is well prepared when they arrive. I don't want the person, let's say it's a teenager and they've been out partying all night till 2 o'clock in the morning, and now they come in and they're still half asleep. So they need to be aware that they need to be functioning at their best. Try and bring school reports if that's relevant. Bring someone to give collateral information, very important. They must bring someone along. And that's why you need a waiting room where that person can also sit while you do the assessment. You need a translator if necessary, and I'll come to that. You need to explain to the person what's going to happen with that information, because you're eliciting very important information from them. It's going into a report that you don't know where that report's going to end up. It could go to, if it's a couple, it could end up in a divorce case. You don't know where the information is going to. So you need to explain to the person what is going to happen to the information that you're aware of and what could possibly happen to the information, so they are fully aware before they give consent. And you need informed written consent from the person. Even if you have consent from the attorneys, you need consent from the person as well. If you're assessing a client, you need consent from both parents, very important. If the client cannot give informed consent, let's say this person is really very badly, he's really had a severe head injury and he doesn't really know what's going on, then you can't really get informed consent from the person, can you? But then it's a bit of a grey area. There's no certainty here. What I just tend to do is I try and get that informed consent of the people involved in that person, the significant others, the person bringing the person, or maybe the parents or the spouse, so that you cover yourself to some extent. A suggestion made in LESAC is that you send out a questionnaire beforehand to get background information, because it makes the interview time shorter. It helps to ask the person what are the problems that you're having and why do you think you're having them, because that helps you gain insight or understand their insight into the situation. And also, if if they, let's say it's somebody coming in with Alzheimer's and they're saying they're having problems with their memory, they suspect maybe they have Alzheimer's. Then, if you've done the assessment, you find yes, indeed, it looks like they have Alzheimer's, then at least they've already suspected that, so it makes it easier to break the news. If they have no idea why they're having a memory problem, and you then discover that they have Alzheimer's, you know how to approach the person then too. You need to approach them a little bit more gently. Always encourage them to try their best. Tell them to expect with the assessment that some of the questions are going to be easy and some of them are going to be difficult. You need to discuss with them whether there will be a feedback session, because some attorneys, many attorneys, they send a person to you, they want you to do the assessment, the report, and they don't want you to give feedback to the patient. And they don't want you to give the report to the patient either, because it can interfere with their ability to work with a person. So one just needs to maybe check that with the attorney who's referring. I like to give people feedback. I think it's the information. But what I do say to people is at some stage, once a case has been settled, that attorney should give your report to that person. And I always say to that person, at some stage you're probably going to get hold of my report. You're going to read through it. If you have any questions at that stage, my name and contact details are on the report. You're welcome to phone me and ask me questions. And, okay, a similar point, will the client receive a copy of the report? You need to discuss it with them beforehand. You don't want them coming to you afterwards and saying, so where's my report? And you have no intention of giving them a report because the attorney asked you not to. You just need to be clear on those things beforehand. Okay, you're going to get into information about the person's social history, their present life circumstances, medical and current medical history, circumstances around the examination. For example, are they being assessed and there's a matter of monetary gain or maybe a custody battle? Cultural background and previous exposure to neuropsychological assessments. Now, estimating premorbid ability. One doesn't always have to estimate a person's premorbid ability. For example, if you're working in a hospital setting and you just need to know how the person's functioning now so that the doctors know what medication to give and the physiotherapist and occupational therapists know what sort of therapy to do, then its premorbid ability is maybe not all that important. But certainly when it comes to medical and legal matters, you have to have an understanding to the extent that you can of the person's premorbid abilities.
And especially for, I'm an industrial psychologist, for me to make a determination in terms of that person's future, I need that, and it helps me a lot.
Okay, thank you, yes. So I suppose you can't make a calculation at all if you don't know what their premorbid abilities were.
Well, the calculation in terms of the actuarial calculation can be done in terms of previous salaries and income.
Okay.
But to make a more accurate determination of what's going to happen in the future based on the past, one need that information.
Thank you for that. Now you'll read about this in LESAC. There's quite a bit of disagreement about what one can use for premorbid abilities, and so the information I'm giving you here, you'll see there's some people that say no, they disagree with that. I think at the end of the day, you need to use more than one way to determine premorbid ability. If you have something like school reports and as a child, well, that's wonderful because that's quite clear. But it's very seldom that we have something that is that clear. Now, vocabulary scores and vocabulary tests like the Bachelor tests. These tend to retain well-established verbal skills and they correlate quite highly with level of education. But that's assuming, of course, that the person doesn't have damage in the verbal areas. But assuming they don't, vocabulary is, in many circumstances, quite a good determinant of premorbid intellectual level or level of education. On the non-verbal side, the picture completion test that you get with the Bachelor tests, along with vocabulary, are the sturdiest tests. And the average of the two, or the highest of the two, if one is markedly lower, could be the estimated premorbid IQ score.
Sorry, why picture completion and not the matrix reasoning?
Now, it's interesting you asked me that, because somewhere along the line I read the matrix reasoning is also a very good measure of premorbid abilities, and when I looked through it for that information from Lezak, now I didn't see it in Lezak, it's probably in another book, but my understanding is that the matrices is also a very good measure of premorbid ability. Information, again the subtest, information subtest in the Virtue scales, and vocabulary, estimated verbal IQ and full scale IQ the best. And block design, picture completion, and object assembly gave the best estimate of premorbid performance IQ. Then you get other tests like the NART and the Virtue test of adult reading, which I have over here. It's just been interesting to find that what it also tends to remain preserved is your ability to know how to pronounce words. So these word reading tests are very difficult words that you can't know how to pronounce them just from looking at the word. You need to have either been quite well read or just had a very good vocabulary to know how to pronounce those words. So these tests are used, and they're quite reliable as premorbid measures. But of course these are now all in English, so you need to have an English patient. It doesn't happen you have an Afrikaans patient or any other language. And then demographic variable formulas, taking into account geographic region, urban, rural residence, occupation, ethnic group, are also quite reliable. But there you need South African statistics to be able to help you with that, which we don't have. The Virtue test of adult reading has some demographic tables that one can use to some extent. And then a combination of word recognition and with demographics is the most predictive. So I sometimes, if I have an English-speaking person, I use the Virtue test of adult reading and I look at their demographic variables, and I look at it with demographic variables and without, to see if there's any significant difference, and looking then also at their vocabulary tests and their picture completion tests and so on, trying to put it all together, one gets an idea of their premorbid abilities. There's the best performance method, which you can read about in Lezak. I'm not going to go into that now. Memory is the least reliable indicator of general cognitive ability. Some people just have excellent memories, but they're maybe not all that good at reasoning or abstract reasoning, and maybe not even all that bright. But they have an excellent, for example, general knowledge, because they just have an excellent memory. On the other hand, you get people who are extremely bright who are terribly absent-minded and forgetful. So memory, you can't rely on that as a premorbid assessment. And the person's level of education and historical background obviously also plays a role. If the person comes from a family where everybody has degrees and they're all professionals, then you can probably expect this person would have performed somewhere in that range. Compared with a person comes from a family where their parents and siblings dropped out in standard grade 8, you can probably expect something similar from that person. So one needs to take all of this into account, and hopefully you'll have quite a sort of picture that hangs together quite well to estimate the person's premorbid ability. Remember, it is always, though, just an estimate. You can't say it with any absolute certainty. Now, during the assessment, you need to observe the person, obviously. You look at their gait, starting off. As they're walking towards your rooms, into your rooms, you look at how are they walking. Are there any problems with their gait? Listen to their speech. How clear is it? How, what is the speed of it? Is there any dysarthria? How they're dressed and their grooming, are they clean? And that, of course, you also need to take within context. If this is somebody who comes from a very wealthy home and they are dirty, and unwashed, then it's significant. Whereas somebody who perhaps is living in a township and doesn't have access to water, you need to just take those things into context. The person's attitude towards the testing and their emotions. Are they tearful? Do they laugh inappropriately? Do they have blunted affect? Are they suspicious? Is there anxiety? Does it look like there's depression? Are they putting in their full effort? Do they behave inappropriately? Do they ask inappropriate questions? Do they get up in the middle of the assessment and leave? And from the time that you get your medical report or you get your referral letter, you have a hypothesis in your mind. You have some information about the person, you have an idea of what it is that's happening here, what it could possibly be, and you tailor your assessment accordingly. However, as you're busy assessing the person, you might be thinking, oh my goodness, now I was completely on the wrong track. And now I've prepared the wrong test, and you might need to drop some tests, add some tests. It might even be necessary that you ask the person to come back for another assessment so you have time to prepare other tests. I've had a situation where I had a child who the medical report said, I think they said she was 5 years old, and it turned out that she was 10. So I prepared for a 5-year-old, only discovered that she's 10. And Sonia luckily had the presence of mind to say, she looks very big for a 5-year-old. Okay. But you develop your hypothesis as you go along. Oh, and I just want to say regarding the hypothesis, you might then, remember now, hopefully you've got somebody who's giving you collateral who's still waiting in your waiting room, or who's going to come and pick the patient up later. There might be some questions you then want to put to them afterwards. Let's say as a child, and you're finding that they've got fine motor problems. You might want to ask the parent, do they have any other difficulties with fine motor problems? Do they struggle to dress themselves, wash themselves, pour themselves something to drink? You might just have some other questions that, while you still have the collateral with you, you can quickly ask. Now, making use of translators and interpreters, this is very important in our country because we have so many people in our country who do not speak English and Afrikaans as their first language, and most of our tests are in English. Every now and again we have an Afrikaans translation, but we have many people who do not speak either of those languages, and the person doing the testing doesn't speak the person's language. So it really is quite tricky, and quite often you need to get a translator or an interpreter in. And that in itself is fraught with difficulties. And in my experience, usually the attorneys send a translator with, but this person is naive in terms of the testing. So I might say to the person, okay, ask her this. And it's supposed to be just a short little question. And then she asks it, and I can tell from the length that she's going to explanation of what this person must do, that she's not putting the question as I'm wanting her to put the question. Or they'll sometimes quickly guide and help because, sometimes interpreters, translators, they're just trying to help. They don't realize that you don't want them to help the person, you're trying to find out what the person does. And especially if you're using a family member, like a mother of a child to be a translator, that mother instinctively wants to help a child. So that is very difficult. Preferably have a trained translator or interpreter. But that is also difficult to find.
The problem is when it's a timed test and that has to be translated, that uses up the available time.
Yes. And there's no clear solution to all of this except to maybe have psychometrists that can do the test, who are familiar with the test, who then have first language and the language of the person that you're testing. Even then, you can't really use the norms because you're not giving the instructions exactly according to the way the test was standardized. But you can get enough information qualitatively to still be able to use that information. Now, this is what LESAC suggests if you have an interpreter who's naive to psychological tests. She says, preferably review the assessment procedures, including intentional and colloquial aspects of the wording of the instructions and test questions, so the translator has a reasonable idea of the normal response expected for any item or test. Now, there's just no way you can do that unless it's a translator that you personally train. And I think we should really try and move more and more towards that, having people that we use who are trained in administering neuropsychological tests. And of course, there need to be people who are registered with the Health Professions Council, because we can't expose the tests to people who are not registered with the Health Professions Council under the Psychology Board. So a psychometrist or another psychologist. You need to try and get the best out of your client. You want to know what are they really capable of. So you need to strike a rapport with them. You don't want to make the person more nervous than they already are. And you need to give continual support and encouragement throughout the process without indicating to them whether they've got the answers right or wrong. Just that was a good try, yes, you're doing so well, let's keep on going, rather than saying, yes, that was right, or you won't say no, that was wrong, but don't say, yes, that was right, unless that's part of the testing procedure. And it helps if you can maintain a relaxed conversational flow throughout the assessment without interrupting the test administration. So if you talk to a person, just keep on chatting to them about the weather and about the this and that, and let's try this. And it really helps a person to relax. Try and limit distractions. Take into account the time of the day. I only do assessments in the morning. If you're testing people in the afternoon, that's really not fair because one has a normal slump in the afternoon. Watch for fatigue. Some people you can only test them for about 2 hours and then they just can't anymore. So you need to look out for that. You can't continue a test if a person is too tired. And it may be necessary to repeat instructions or even paraphrase them. Now, we've all been taught that when you do a test, you give the instructions exactly as they've been given. But sometimes, depending on what has happened to the person, sometimes you need to shorten the test instructions or simplify the test instructions. Sometimes test instructions are so outdated that they use language we don't really use anymore. So you need to give instructions in your own way, knowing that by doing that, your norms, you cannot use your norms with that much confidence. However, at the end of the day, the meaning of the instructions should be the same for all people rather than the wording. You want to try and get the most out of this person. And you need to look out for poor effort. Now, common problems that we have with the assessment of people with brain disorders, they're not always that alert. If a person's not alert, I've often been called to do an assessment in a hospital and I get that the person's sleeping. And then, by the time the nurses have woken them up, they're so groggy. I think, this is absolutely pointless. They've got to be alert. That's why I like people to come to my office. They're mentally more prepared. Sometimes they have problems with attention because of the nature of the injury, and they really struggle to concentrate. And you have to maybe work quite hard at getting the attention back to the test each time. People with memory disorders might not remember the test instructions so well. So in that case, you might find you have to keep repeating the instructions. Like with a vocabulary test, you say, what does so-and-so mean? And then later you can just give the words. But if somebody's struggling with their memory, you might have to keep saying, what does this mean? What does that mean? Or what is the similarity between this and this? Or this and this are both. And keep giving the instructions. Fatigue, I've already mentioned. Medication. Some people can be very heavily medicated, particularly in a hospital setting where you're also walking and see the person so groggy from medication. It doesn't help you test them. And then one just needs to have a discussion with the doctor that put the person on the medication. Sometimes they are in a lot of pain. Perhaps they've been orthopedic injuries, and we all know we struggle to concentrate if we're in pain. So one needs to take that into consideration. Sometimes they're just not motivated. They don't understand why they've been brought to the assessment. They don't agree with their families that they need to go into a home, and they do not want to do these tests, and they're just not cooperative. And again, unless if a person's not cooperative, you need their cooperation to be able to assess them from a legal point of view. So, hopefully you've got cooperative clients. Anxiety, stress, and distress. If a person is so nervous and anxious, they won't be able to concentrate so well either. So you need to do your best to put the person at ease. Depression, you need to be aware of that. Test for depression if you think the person might be depressed. Don't just go by your clinical observations. And if the person is depressed, well, then you can probably expect memory difficulties anyway. So maybe that person should then first have treatment for depression before you try and test their memory and try and make any conclusions draw any conclusions regarding their memory. Frustration can be quite difficult to manage in a testing session, and it can also interfere with their best performance. Disorders of executive function. That can interfere a lot with your testing procedure. You might get somebody just walk up in the middle of the assessment and walk out, or they maybe really lack insight into what they're supposed to be doing and what appropriate behavior is, and it can be quite difficult to manage. And I've added in their hunger. That's not in Lizak's book, but I know that we get people coming to our assessments and they're hungry. And I always ask, have you had breakfast? And if they haven't, because some people just haven't, they haven't had a chance, or maybe they don't usually have breakfast, And then I ask, are you hungry? And if they're hungry, I normally keep little packs of cup of soup and so on, and just give them something to eat first, because you can't concentrate if you're hungry. Now, once you've done the assessment, you need to try and find the appropriate norms. In South Africa, we don't have a lot of norms, but those that we do have, we need to try and use if they're appropriate. And if you don't have appropriate norms, then try to compare across the norms that you do have to see if they make any significant difference. So you, for example, find some tests will have norms for a certain age group, a younger age group, and then an older age group, and not for the in-between. So you need to then compare, well, how do they do in the older age group, in the younger age group, and then try and see if there's any significant difference, and try and gain an understanding from it that way. And then 3 books that I can highly recommend. You've already got Lizak. I've already mentioned a compendium of neuropsychological tests. What I haven't mentioned is the Mitrashina book, Normative Data for Neuropsychological Assessment, which also has a lot of norms, and that could be very useful. Okay. Now, once you've done the tests, you've got the scores, you've chosen your norms, you need to then compare with the estimated pre-morbid functioning. You cannot assume everybody functions in the average range. So if somebody's functioning with your test, they're functioning in the average range, that only tells you something if you know what their pre-morbid abilities were. If their pre-morbid functioning was in the average range, well, then there's not really anything of significance unless there's some other things that really stand out. If this person looks like they were in the superior or very superior range, then for them to be performing in the average range is very significant. So you need to think about the pre-morbid functioning. If there's only one descriptive category higher or lower than expected, it's not significant. So let's say you're expecting the person to perform in the average range, and you do a test and they perform in the lower average range. That's not significant, because that could just be due to sort of just errors of measurement. It could be due to a number of factors. However, if you're expecting them to do in the average range and they'll fall in the borderline range, then that's significant. Or if you expect them to perform in the high average range and they're now performing in the low average range, that's significant. Okay, but if you expect them to perform in the high average range and they're functioning in the average range, that's not really significant. It's interesting, it's noteworthy, but it's not significant. And, if more than 2 standard deviations difference, then that's significant. And 1 or 2 standard deviations just suggests a trend. Now I want to just talk about standard deviations and things first. But before I do that, yes?
So if you look at the average range, it's a huge category.
Yes.
Would one, for instance, describe in terms of where in that average range the person falls?
No. Because if they fall in the average range, they are average. Whether, I want to just go to that little table. So let's say somebody is in the average range, okay? Bearing in mind now that high average is outside of this, and low average is outside of this section. Whether they that side of average, or that side of average, or that side of average, it makes no difference, because they are still average. And the reason I say it makes no difference is because of the standard error of measurement. Because every test isn't perfect, and every testing procedure isn't perfect. So there's always a standard error of measurement. If somebody has scored a 10, again, if you think now the subtest, like the Vechsler subtest, you know that the mean is 10. If they score, you can score from 0 to 19. Let's say this person scored 10, slap bang in the mean. Okay. If they score 9, or if they score 11, it doesn't mean that it's any different to the other one. So if you score 9, it's not lower than the 11, because it still falls within the average. It still falls within that category. You can't say that it's lower, and that's because of the standard error of measurement. And you will read about that in LISAC. And that is very important when one's arguing about your test findings. It's only significant when you're moving out of that category. And then only significant, as I say, if there's more than one category difference between your finding. So let's say somebody scores in the average range in something and low average in something else. That's not significant. It could also just be due to testing error. However, If someone's high average and something else is low average, then it's significantly different. Okay. Am I making sense? All right. Just want to go back. Okay. Now, when you write your reports, be careful what terms you use. Don't, in the same report, refer to high average and above average, unless you've defined exactly what you mean by high average and above average. Because above average could be anything above average. High average has a more specific meaning. And if you, in your report, you're referring to high average and above average, you're confusing the reader. So what I want to suggest is at the end of your report, have a little table of what you mean by the terms that you use. If you say high average, exactly what do you mean by that? And then use this table that you will get in LESAC. It uses IQ scores, Z scores, which is the percentage included, percentiles, and the percentage included in that. Use that little table so that if you're standing in court and they say to you, well, what do you mean by borderline? What is borderline compared to, for example, extremely low? You can just look at your little table and you can explain it. I recommend that you make use of percentiles or Z scores in your report. I prefer not to mix them up. You know, if you're going to do percentiles, stick to percentiles. If you're going to do Z scores, stick to Z scores. The problem with, sorry? T-scores, I would prefer, you can use T-scores, but I prefer to convert them back to Z scores or percentiles. And you'll see in your LESAC you have the tables that where you can convert a T-score to a Z score or a percentile. The reason I like to use Z scores is because you can use it with any test that you've got, assuming, of course, that the test is you know, standard, falls on a bell curve. Because when you do a test, you will always have, when you look up the norms, you'll always have the mean and the standard deviation. Sometimes you'll have percentiles, but you'll almost always have mean and standard deviation, so you can always work out your Z score. And I'm going to get to that in a moment as well. Be careful of scores that are over-inclusive, such as with summed or average test battery scores. So if you have a battery of tests, like the R bands or the Bachelor test, sometimes they group them. So you get, for example, a performance, a processing speed index, or a memory index, like with a Bachelor. But it loses its meaning because you're then combining, you know, each sub-test has its own skills that are needed to be able to do it. So by getting this average score, it actually doesn't mean anything. If it's low, what are you low on? If it's high, okay, maybe it's high, then you know you're high in just about everything, but you are losing the value of using each sub-test on its own. So try not to do that. And of course, it's important to observe how a client takes a test. And I want to encourage you to read through LESAC, Marquis, Spreen and Strauss, where they talk about the block designs test, and they've got various descriptions of what you can learn from how the person does the block designs. Do they start from the left? Do they start from the top? Do they do this? Do they do that? So watch what the person does very carefully. And then also bear in mind that each neuropsychological test measures more than one aspect of brain functioning. If you're doing the digit symbol coding test, you're testing processing speed, but if the person has problems seeing, they're going to do poorly. If they have motor problems, they're going to do poorly. If they have problems with scanning, they're going to do poorly. So you're not only measuring that, you need to bear that in mind. The reason I've got the slide is just to remind you how to work out a Z score. That you'll also see in LESAC. Your Z score is your score. Let's say the person has done what test? Let's say that, like the word naming test. And they thought of, let's say it's animals, they thought of 19, they could name 19 animals. Now 19 is your raw score. Then you minus you've got your table of norms, you look for your mean for that age group, person, and so on, mean. So you've got your score minus the mean divided by the standard deviation, and then you've got your Z score. And if your Z score is between 0 and -6 or +6, you know the person's average. And so you can look at the tables to look at, are they above average, below average, significant, extremely low, etc. Now, regarding a feedback session, something that Lizak, when I was preparing for this, Lizak mentioned that I've never done before, and in fact I've never heard of it before, but I think it's a very good idea. She has what she calls an interpretive interview, where after she's done the test and she's written the report and so on, she calls the person in and to give them feedback. But part of the feedback is to check her findings with their reality and to confirm certain things, you know, because let's say you find they struggle with their memory, and now you want to ask, well, do you struggle, you know, whatever, but you try and get more information from them to see if they're understanding you correctly. I mean, to see if your findings are correct. And that extra information that they then get bolsters your argument, and then you go and you finalize your report using that extra information. I think that's a very good idea. It's not always practical, I think, to get a person back like that. But I do think as far as possible one should give feedback to people about what your findings are. Again, we've got the question about, you know, if it's a medical legal case, you might have to just delay giving the feedback. Describe positives and negatives. You don't want to write a report that is just full of everything that's wrong. You do want to mention a few things, you know, that the person is capable of doing, because you don't want to demotivate the person who's busy reading it. That being said, you can't put in information that is completely irrelevant. So try and keep it relevant, otherwise your report's going to get too long. Try to get them to relate what you're saying in real life. Be honest. Doesn't help you beat around the bush. You have to say what you found. And if it's not good news, you need to just convey it in a gentle way. What I normally do, if I'm conveying bad news, you know, for example, I think you have Alzheimer's, is I normally just start saying, look, this is what I found. You have problems with this type of memory, that type of memory. Is this what you're finding? And if you can get them to say, yes, that's what I'm finding, and so on, and then they're feeling more understood, then you say, okay, well, now we've got an explanation for what's happening to you. It looks like this is the situation. And I have never, ever had somebody who leaves my office feeling sad or upset or cross or anything like that. It just depends on how you approach it, but often you're giving them quite bad news. And then do also their feedback mention what they're still good at. Because some people, if they've had strokes or something, they think, well, I'm totally useless now, I can't do anything, which is not true. There are a lot of things that they can still do. Okay, regarding report writing, try and keep it as short as possible. Include only information of relevance. There's information you need to include. I'm not going to go through that now. It helps to put the person's name in the header or the footer, so that with each page you've got that name, and do number your pages, because if some other staple comes undone at the attorney's office something and all the pages fall on the floor, they can see what pages belong to your report. Do number the paragraphs, because if you're in court, they want to refer to paragraph number whatever. It just makes it much more easy, rather than saying, hey, turn to page 5, the third paragraph from the top, you know, just number them. It makes it much easier. Obviously you need to sign it, and then just a mention, just something that SACNA feels very strongly about. Association with SACNA must only be indicated if the person's a full SACNA member, and then at the end of the report with the examiner's name and signature. Some people put it in their letterhead. SACNA feels that's not appropriate. It shouldn't go in the letterhead. It goes at the end of your report, and only if you're a full SACNA member can you actually make any reference to SACNA.
Does one have to include your own expertise, your qualification?
On your letterhead, you will say what your qualification is. Whether you are a counseling psychologist, an industrial psychologist, you know, you will say what it is with your degrees. You've got a PhD in this and that and that. That's what you put. If you're doing medical legal work, it's very important that you send your CV to the attorney as well, because he has to argue that you are an expert in court. I'm not going to go through this. You can just read that on the slide later. What I do just want to say is that you need to aim your report at 3 different people. Firstly, the client. The client is going to probably read it at some stage, and you need to write it in a respectful way, in a way that's not going to do any harm to this client. So be careful how you word your report. You're also going to have lay people, psychologically lay people, reading a report, such as attorneys. So you can't use too technical language. You've got to use lay terms. If you use a technical term, explain what you mean. Otherwise, it creates confusion. And then other neuropsychologists are likely to read your report at some stage, maybe because they're asked by the opposing attorneys they get their own neuropsychologist, and they need to be able to read your report. So you need to have your test findings in there so they can compare apples to apples. If you say, this is what I found with delayed memory, well, what test did you use? They need to be able to compare. Not only opposing neuropsychologists, but also sometimes years later the person needs to be retested for some reason, see if there's been a deterioration, and then or an improvement on medication, and then that person's going to be referred to a neuropsychologist. That neuropsychologist needs to see how you got to your findings, so that they can then compare and directly and see if there's been an improvement or a deterioration. Okay, so you're writing for 3 groups of people, and you need to bear that in mind. I'm not going to go through the common errors that neuropsychologists can make. I'm going to just point out 1 or 2. No, I am going to go through it quickly. This comes partly from those of you who've registered for the exam. You would have got an email from Frances Hemp, and she would have said, this is what you need to, understanding of and so on. And then she mentions in there an article by Russell Bauer. Now, that's quite new. That hasn't been mentioned before, but I went and I just looked up this article and I got the main facts from the article. So I'm going to go through this quite quickly, all right? Neuropsychological tests are tests of brain damage, but that does not mean that if a person scored poorly on a neuropsychological test, that he or she necessarily has brain damage, okay? Neuropsychological complaints are not necessarily valid indicators of real-life neuropsychological deficit. The ecological validity of most neuropsychological test procedures is not known. 2 deficits are not necessarily worse than 1, okay? So, because it might be the same area that's damaged. All functions cannot be expected to be normal or above average in the intact individual. You might have a person who started off in the borderline or even extremely low range. It is possible for neuropsychological results to reveal effects of subtle brain damage not seen on neuroradiological examination, but that does not mean that in the absence of neurologic confirmation, the neuropsychological test predictions are necessarily right. You can just think this through when you read through it again. All neuropsychological data is subject to interpretation by the professional. What one sees as normal may be seen as abnormal by a more discerning neuropsychologist. What is often at the crux of differences in interpretation is that different standards of interpretation or different impairment cutoffs are being applied. Neuropsychological tests cannot be applied in all settings and will not work equally well in all situations. I think that's fairly obvious. Patient complaints obtained through self-report are not important and reliable sources of information about the nature of cognitive deficits because they can be subject to a host of distortions. Neuropsychological data and the patient interview is not sufficient in itself in inferring past health, cognitive performance, and psychiatric history. One needs to try and get some evidence. You cannot tell what a test measures by looking at its name. I think that's a bit obvious, but this is what they mentioned, so I thought I'd better put that in. Okay. Every test does not have its own special location in the brain. If you're doing the digits backwards, it doesn't mean that it only measures frontal lobe functions, it measures other things too. Beware of confirmatory bias, the tendency to seek information to support your hypothesis and ignore contradicting evidence. So you have a certain idea, be careful not to fall into the trap of then ignoring the things that don't back up that idea. These points, by the way, are now in addition to that Russell Bauer article, and these you'll find in LESAC. A single dramatic finding that contradicts other findings can be overinterpreted. If it's a shoot out once or funny little score, you can look at it very carefully. You might, don't overinterpret it. Regard signs that can occur with more than one condition as suggestive and not an indicator of a condition. So, if somebody has a certain difficulty, and it matches with a certain disorder, but it also matches other disorders, doesn't mean they have this disorder. You've got to bear in mind that it could match other disorders. False negatives, absence of low scores can occur with a brain-injured person who has not been assessed appropriately. So you can get a brain-injured person, particularly like a mildly brain-injured person, and depending on how you're testing, you might not pick up that there are actually problems, and they might just look like there are no problems. Okay. This is the last section about forensic work and forensic psychology and appearing in court. The most important thing that you need to remember is your job, your role is you're there to help the court. You're not there to help the referring attorney. You're not there to help the patient, although if you can help, that'll be great. You're there to help the court, because the court doesn't understand the technical things that a neuropsychologist understands. So they call you to explain it to them, because that judge needs to make a sound judgment. So you cannot be biased towards one side or the other. You have to be as honest and truthful as you possibly can, because you're there to help the court.
Without telling the court what type of judgment should be made.
Don't tell the judge what he should be thinking. Okay? And don't ever tell an attorney what he should be thinking either. They can take great offense. Okay. Expert witnesses are expected to have knowledge and skill expected in the field they purport to be an expert in. If you are going to say you're a neuropsychologist, the court is going to expect you to have the expertise of a neuropsychologist. So until you feel entirely comfortable, don't call yourself a neuropsychologist or an expert in neuropsychologist. Just call yourself what you are. You're a clinical psychologist, or you're an educational psychologist, or counseling psychologist with special interest in neuropsychology. And then they're going to expect that from you, not absolute expertise in neuropsychology. Working on a contingency basis can be considered unethical. I don't know if you know what a contingency basis is. Some attorneys will contact you and they say to you, I want you to assess this patient, but I'm only going to pay you if we win the case. Okay? They do that because they often work that way. They often take clients and they say, okay, you don't have to pay me anything, only if I win this case, then you can pay me something from what you've got, from what you've received. So they expect other people to do the same, but it's completely unethical, because obviously then even if you're not biased, the court is going to assume you're biased, but you're going to want to show that the person has a brain deficit. Okay. So and there are attorneys who ask it, so just be very clear that you don't do it that way.
So in the case of pro bono work?
Pro bono work is different, because you're saying you're doing it for free, but then the understanding is right from the start that you're doing it for free, no matter what the outcome is of the case. And I would have that written down as well, and maybe have it in the attorney's words as well, just in case. Your clinical opinion is not worth anything without good evidence for it. It doesn't help you stand in the witness box and say, but my opinion is. Unless you can back up why you say your opinion is what it is, it's completely worthless. There was a time where experts could stand in the witness box and say, look, my professional opinion is this, but it doesn't hold water anymore. You've got to say why. Whenever you write a report, assume that report will go to court. So you have to write as if it's going to go to court. Use various sources of information to form a global opinion, like your medical documents, your report complaints, your collateral information, neuropsychological tests, understanding of anatomy and neurophysiology. You need to use all of your knowledge to come to a sound opinion.
Could I just add, these reports are meant for the court. So if you get the case number, please add it. It helps the administration.
Well, that's a very interesting point. Never thought of that. Thank you. Do not move outside your personal field of expertise. You can be a neuropsychologist, but you may have no expertise in, for example, children, or you have no expertise in stroke. So don't pretend you do. If you don't have expertise, you don't. Don't move outside your field of expertise. And it goes wider than that. As neuropsychologists, you cannot say, what sort of work the person might have been able to do or should be able to do in the future. That's for the industrial psychologist to say. So be very careful to stay within your field of expertise. And if you're in court and you're asked to give an opinion on something that you feel you don't really know because you're not an expert in that, then you just say, I can't answer that, that's outside my field of expertise. They might then say, well, just venture a guess because they don't have an expert in that field, in which case that's fine. But you say, but you're saying this, but the court must understand this is not your field of expertise. Okay. And then quite importantly for us all, a lack of a full understanding of a subject does not render useless all fact and opinion on that subject. So you've got a case, but you've had limited resources. You were called out to a place, you didn't have all the tests that you needed there. It was an emergency situation. Although, you use what you can to get to an opinion. Not all information is useless if you don't have all the information. Okay, so you just form an opinion reasonably on what resources, what information you have available. It's very useful to include at the end of your report that this information is based on the findings, information, or this opinion is based on the findings or the information available and might change if other information becomes available. You still help the court even if you can't form a very full opinion, but obviously try and use as much information as you can before you form your opinion. And then work under supervision until you feel secure in your assessments. And even once you feel confident in your expertise, make use of supervision if you're feeling uncertain about any particular case. It's just wise to get extra guidance. In terms of appearing in court, prepare for court appearances by going through your and other reports related to the case thoroughly beforehand. You need to dress neatly, be respectable and polite to all the participants, have the best manners you've ever put on. Be objective. You may not choose sides. Be honest and exact in what you say. Use the words possible, which means less than 50% chance, and probable, which means more than 50% chance, correctly. So if if you're saying this person probably has Alzheimer's, then it must be because you're more than 50% sure that this person has. If you say this person possibly has Alzheimer's, then it's because you're less than 50% sure that person has, and you need to use those terms correctly because in the legal system those terms are very, very important. Think carefully before you speak. This is now if you're in the witness box, and do not be shy to ask for a moment to think a question through. If they ask you a question, often you're feeling a bit nervous, and they ask you something, you think, oh, I don't know answer. You can say, please just give me a moment until you've just thought it through, and you can of course say, please repeat the question, or can you, what is this what you're asking? Just make sure you understand what the question is. You're allowed to take your time to just think it through before you answer. Okay, there we go. Ask for questions to be repeated or clarified if you do not understand them clearly. Be prepared to explain technical jargon in layman's terms, but hopefully you've written your report in such a way that you've already explained things in layman's terms. Be patient and flexible with your time. It is difficult for participants to predict exactly when and for how long the court will need you. So you need to be flexible with your time if you
perhaps
go to
just
court.
add, part of your preparation is a consultation with that attorney or the advocate. That person has to know exactly what you are going to answer on his or her questions.
Quite right.
And to prepare you for cross-questioning by the other side.
Yes. It's the attorney's job to prepare you properly as an expert witness. You're quite right. So you will sit with them beforehand, and they will ask you the types of questions, firstly, that they will ask you, and what they think their opponents are going to ask under cross-examination to prepare you. If you find yourself forced to say yes or no about something, but you feel that further clarification is necessary, you may ask a judge if you may clarify the issue. But you'll sometimes you get an advocate say, yes or no, is this the case? And you think, well, if I say yes, then it's actually leaving out really important information. So you can turn to the judge and say, I'd like to be able to elaborate on my answer because I think it's important for that, for the court to understand, all the issues around this. Back up your opinion with facts and or careful reasoning. Keep control of your emotions, because one of the techniques that the advocates love to use to get you upset. And when you're upset or you're nervous or you're anxious, that's when you tend to say the wrong things and not say the right things and so on. So try and keep control of your emotions. Never, ever, ever lose your temper in court. That's just the very, very worst thing to do. Do not take any documentation into the witness box with you. All the reports that you would have gone through, including your report, is in a file at the witness box. You will be referring to that file. You can't take anything else with you. So that's why I say, in your report, put your little table with your stats and things, because you can't take it with you. Okay, and you need to be able to, in your report, be able to refer to those things. And then something that Alfred Allen says we absolutely have to do. Take psychometric test manuals to court with you in case you need to ask to refer to them. Example regarding the validity and reliability of tests. These little manuals, take them with, don't take them to the witness box, but just have them in the room, so that if somebody asks you, what is the validity of this test, you're not going to remember, but you can go look it up quickly. And then, do not speak to anybody except your attorney or your advocate if taking a break while still under oath in evidence of chief. So while you're in the witness box and they're taking a tea break, you may speak to advocate and attorney, but to nobody else. However, once you're under cross-examination, you may not speak to anybody at all. Always direct your answers or questions to the judge. You don't speak, the advocate asks you the questions, you attorney, you speak to the judge. Okay. You address the judge as my lord or my lady, if there is a male or female judge respectively. Watch the speed of the judge's writing and pace your speech accordingly. So he might be writing down what you say. So you watch how quickly he's writing, you wait for him to finish writing before you continue. Otherwise you speak too much and he hasn't got a chance to write it all down and you frustrate him. Okay. Admit as soon as possible if you have formed a new opinion or realize that you've made a mistake. We are human beings. If while you're standing there you think, oh my goodness, I actually never thought of that, that does actually change my opinion, then just say that. Remember, you're there to try and get to the truth of the matter and to assist the court. So even if it's a little bit embarrassing to you, that is what you need to do. Okay. Remain committed to the very end of the process. It can be a very lengthy process, just bear with it, remain committed. I've mentioned already, don't lose your temper. And before even attempting medico-legal work, ensure that you have the required expertise. And if you cannot remain committed to the very end of the medico-legal process, let's say because you're going to be retiring or you're going to be immigrating, then don't take on the case, because that's very disruptive to the whole court procedure if suddenly you're not available anymore. And then my final word, don't guess. Not even an educated guess. You need something to back up what you're saying. Don't follow theories or use tests without a sound research basis. You want evidence. You want an evidence-based practice. Stay up to date with the newest findings. That's quite difficult, but to the extent that you can. Regularly attend workshops, conferences, and meetings such as SACNA regional meetings, because that's how you stay up to date with the newest information. Buy the newest test editions where applicable. It's not always applicable. Understand the applicability of the test for particular patients. And that you can read up in books like LISAC, and research your suspected diagnosis and differential diagnosis. Really look into it. I don't think there's a case that goes by that I don't take up my books again and just go through it again. Could it be this? Could it be that? Do I know about? Because you don't always remember all this information. It's just too much information. Thank you very much. This is your required reading. It's a lot of reading. It's a number of chapters in LISAC, but I've gone through the gist of it. And you'll find that this is really, these are the nuts and bolts and nitty-gritty of neuropsychological assessment. There are many things that can go wrong, and you just need to know how to manage things that go wrong. Okay, thank you very much.